And our keynote speaker, Dr. Paul Pepe, needs no introductions. Those of you who were here last year remember his great speech. Those of you who were downstairs with us in the Directors Symposium know about him, but I'm just going to tell you very briefly some of the accolades that Dr. Pepe has earned. He is the Director of Medical Emergency Services for Public Safety, Public Health, and Homeland Security for the city of Dallas, Texas. And he's a full professor of medicine, surgery, and peds at the University of Texas Southwestern Medical Center and Parkland Health and Hospital Systems, also in Dallas, which is one of the largest in the country, and it's an incredible place. So we're privileged to have Dr. Pepe join us, and please join me in welcoming him.
Good afternoon. I am for you today to speak of next hour for the problems with emergency services and the intervention for trauma, elemental or detrimental. In my country, I was a brain surgeon, and here I'm forced to be an EMS physician and must work with, just joking, by the way, I'm not talking like that if you don't know me, okay? So just thought we'd get it started off on the right foot here. I do have, actually, I've learned to speak English because I had to for various reasons. I'll show you why here in just a second as I pull up another slide here. Okay, here we go. Oops, got to do something real quick here on the scan. It looks like we had an interesting phenomenon take place there. Let's see what happens now. There we go. So this is a German Coast Guard dispatcher the first day on the job.
Das hier ist mein Sektor.
Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät und das Gerät.
Überlebensradar.
Mayday, Mayday. Hello, can you hear us? Can you hear us? Can you... Over. We are sinking. We are sinking.
Hello? This is the German Coast Guard.
We are sinking. We're sinking.
What are you thinking about?
So I decided to improve my English this year and have come along to join you here. So I'm really pleased to be here. I was really excited when I first got asked to come and speak to you. Then I found out why they asked me to be here, okay? Apparently, they have a bylaw here, the committee. You know, you're used to very attractive, celebrity kind of guests that come up and speak to you. And apparently, there's a little clause that's kind of like an affirmative action that you have to have kind of a certain number of, let's say, aesthetically challenged people come and speak to you too. So here I am. So I was a little upset when I first heard about that. And, but there may be something to it. A few weeks ago, I was at a network TV interview, for example, and they had me in, what was that, they had me in makeup or whatever. They immediately called for backup, okay? So I figured there might be something to what they're saying at this point in time. But I think the reason why they picked me to be here is that a few years ago, as a young child, I had an early interest in exploring the universe orally when I was about a year of age or so on. And so that got me into doing things and eventually set me up for ACLS. Everybody knows what that is, right? An alternative clinical lifestyle, namely that in the streets, okay? And so what I'm going to go over today is going to be deja vu all over again for many of you, but on the other hand, I hope to make some new teaching points and hopefully not be totally in rocket science land for you and give you some new information that you may not have heard about and take you to the next area where the envelope gets pushed. I like this. Like most veterinary students, Doreen breezes through chapter 9. So here's the vet textbook looking at taking care of horses, right? Diagnosis, broken legs, infected eye, splayed hoof, then treatment, shoot, 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 shoot. So we're going to breeze through here. Let's start breezing through today. I've been asked to cover a lot of stuff. My background is not only in the trauma centers, but also on the streets, etc. And I'm going to try to bring you a little bit of a perspective of what we do before we get to the operating room. My area is emergency care, and my emergency care begins the time they pick up the telephone to call us, as far as I'm concerned. So whether it's a dispatch office or whatever. But when it comes to trauma, which is one of the things I was asked to speak about today, What's the key thing? The key thing is stop the bleeding. That's where we lose most people. It's the major principle of bleeding. And we know it's the key thing because it says right there in the Bible, for the life of all flesh is the blood thereof. So it becomes a really important thing traditionally, but also from a medical physiological point of view, as we'll go through, we'll see how important that is. So that's the reason why we started trauma centers. Why did we do that? So we could get to places where we could stop the bleeding, whether it's in the brain or in the chest or the abdomen or whatever. We could have a surgeon standing by because a chance to cut is a chance to cure. And that's the idea. But the question is, and why I'm here today, is the surgical theater all we need? Is there anything we could do preoperatively, pre-hospital, emergency department that will change the outcome? Does preoperative care change the outcome? And everybody in this room says, oh, absolutely it does. It should be, and because that's why we're here. Or is it just scoop and run? Is there anything we really do, particularly in the patient who is very ill and critically injured and at risk of dying? So it turns out that the ABCs are what we're always told to look at. So the first thing is about the endotracheal tube. And there's been a lot of things about the endotracheal tube and bad mouthing it, and part of the reason why that has occurred is that people have found some bad outcomes associated with endotracheal intubation in various systems. And in those systems, for example, in general, if you correlate endotracheal intubation with outcome, what's it going to correlate with? A bad outcome, because the sickest patients get intubated. Well, then the way you would study that is how? How would you study that? Well, you'd have a side-by-side study where half the patients get tubed and half the don't. They have the same criteria, and half of them get it and half don't. Well, they did that, for example, for pediatric cardiac arrest a few years ago. The only problem with that particular study is that they did a lot of extra training for bag valve mass, but that's okay. You improve the care both on the bag valve mass side and the endotracheal tube side. But what also happened is they did it in a system in which there were 2,600 paramedics who were trained for the study to do it, and there was only 125 intubations in children in that 1 year, okay? Which means if you're a medic, you had a chance of about 1 in 20 of getting that tube in, or 1 in every 20 years, okay? And your partner gets to get one in. Let's say if you get one in, then your partners, now their odds go to like 1 in 40 chance of getting that tube. So the point being is that, is that you just don't get experience in certain systems where there's a lot, if everybody on every corner is a paramedic, they don't get it. So is endotracheal intubation a good thing to advise for that system? Probably not. I wouldn't. And I've been in places where I'll say, I don't think this is the right place. But in other places where they have highly skilled medics, for example, if you have 60 medics to handle a population of 1 million, by virtue of a tiered response system, they keep pretty good skill sets, and they get their skill sets acquired pretty rapidly so they can let the young champions take over, and that will be okay. And in fact, under such circumstances, in both 2 cities where I've worked, both in Houston and Seattle, endotracheal intubation actually correlated with a good outcome under these circumstances, even in trauma. So that's interesting. What's that all about? Well, recently, there were some studies done, particularly out in San Diego is a good example, where they looked at those patients who were getting rapid sequence induction intubation. And they showed it was quite feasible. But then when they looked at outcomes, what happened? They actually found out that those who got intubated had worse outcomes. So what's going on there, all right? Well, when they drilled down on it, they found one interesting thing. The one interesting thing they found out is that it correlated with, and correlation is just a correlation, they correlated it with a low carbon dioxide level, or as they called it, hyperventilation, by definition. So they looked at that. So hyperventilation, a low carbon dioxide correlated with a bad outcome. So why would that be? Well, the usual suspects, as they in their usual Casablanca approach, round up the usual suspects, was that you were squeezing down on the blood vessels in the brain because carbon dioxide would do something there. Or you cause an alkalinity of the bloodstream so you don't deliver oxygen to the tissues as well, or depresses the myocardium. But in fact, what I think it really was, in a contra Casablanca philosophy, not round up the usual suspects, but today actually may become a usual suspect, is the culprit is associated with positive pressure ventilation. All right, what does that mean? When you and I take a deep breath, we have dome-shaped muscles below our chest called the diaphragm. And when we contract our diaphragms, when that diaphragm contracts, it's a muscle that comes down like this and contracts this, and it pulls the lung down in a very specific architecture. In essence, it's kind of like taking a syringe and going, and you're sucking the air in. But not only do you suck air in as you take that syringe, you're also sucking blood into the chest. And that's really an important part of what you do on a day-to-day basis. In fact, if your blood is pumping harder, like during exercise, you got to pump more blood out. Well, you got to suck more blood in as well. You're not only blowing off more CO2, but you're also getting rid of, you're getting more blood back into the chest. But what happens when we try to rescue them? What we're not doing is pulling the lungs open, we're pushing them open. And that causes positive pressure breathing. Now, you and I can put you on a ventilator today and go, and then you'd immediately get rid of the breath. Inhibits transiently, the blood flow, but you're going, and there's plenty of time with your heart beating, going on fine. You have good volume status in your bloodstream, and it's not a problem for you. But if you are in a low volume, who's going to be in trouble? Well, those who have a low volume state are going to get into trouble because they can't fill the heart as fast. If you've lost a lot of blood, your preload, so to speak, your venous return is lower than usual. Or a patient, say, with COPD, because they can't get that air out as fast, etc. So, but what we're concentrating on is trauma. And look at this. I did an experiment a couple of years ago just to demonstrate what I'm telling you about. So we did an experiment in which we looked at a model of moderate hemorrhage. Just moderate, not severe. This wouldn't even, in a patient, we wouldn't even put an endotracheal tube in here because it's just so moderate. It just, you may have a little bit of a low blood pressure, or maybe the blood pressure is kind of normalish, but you've had, a pretty significant amount of your blood taken out, but you're not unconscious and so on. What we showed was, for example, if you look at this thing, on the top, that line, that wave-like thing in green, those are breaths. And the breaths are not coming that often. They're coming once every 5 seconds. 200,000, 300,000, 400,000, like that. That's not a lot when I watch people ventilate, by the way, okay? And so, and then what happens, this thing down the bottom is the blood pressure in blue. And so at the bottom of that blue, where the red lines are, that kind of goes along with your coronary perfusion pressure. And what happens here is that with each breath, boom, look what happens to coronary perfusion pressure. It gets knocked down. Boom, here it goes again. When I did it in animals that had severe hemorrhage, like where we would tube, we couldn't keep them alive. It's profound what happens to them when you give them positive pressure breathing. So what happened in our system, we knew that this is a problem, so we would hardly ever give a breath. We might give a breath once every 10 seconds or something like that. Because in a low flow state, you don't need to get rid of that much carbon dioxide because there isn't much oxygen being consumed to the tissues. There's not much being returned because there's not much carbon dioxide being produced. And it's not even being returned, so you don't have to worry about getting rid of it. And if with an occasional lung inflation, you basically keep the bloodstream oxygenated. So here's an example. What I did here in this picture, I actually physically took this picture at the time of the experiment with my camera. With my little handheld, boom, there, I took the picture. Then if you digitize the same data, you can see it even more clearly. Over the area under the curve in pink shows you how much blood is going to the coronary arteries. And look at that on the left. At 6 breaths per minute, you're getting basically a lot of red. In fact, it looks like that the biggest problem with the blood pressure was actually the ventilation, not anything to do with the underlying state. And if you look at the 12 breaths per minute on the other side, you can see how much it knocks down the blood pressure. So it obviously is a big issue that overzealous ventilation is a problem. You don't need to ventilate in a low flow state. And that's where we're in. We're in a low flow state when we're like bleeding out, etc. So if you look at this in terms of brain tissue perfusion, for example, I've done some other studies where we actually look and see how much oxygen is getting eaten by the brain, how much is actually delivering there. But that's the key thing. What's the brain getting? And in this study here, we look at brain tissue perfusion after 40 minutes of shock. The thing on the left with the highest level, that is the best tissue perfusion, has to do when you're only giving 6 breaths per minute in that one versus the 12, which is where you have the very low level, okay? And then the same thing is true if you look at situations like lactic acid, because everybody's worried about getting lactic acid accumulation, so you got to blow it off or something like that. You kind of compensate for it. Well, look at this here. In blue is the 12 breaths per minute, and the others are either titrated to carbon dioxide, end-tidal CO2, or a rate of 6. The point being is that you're worse off when you're overzealously ventilating, and you're still oxygenating the blood during this period of time, and the brain is getting good oxygenation. The issue here is that we have caused a problem. The problem is that, for example, in our system, we only gave 5 breaths per minute, and these people were surviving. Why were they surviving? Because we weren't knocking out their cardiac output by overzealous ventilation. So the culprit is overzealous ventilation. If you go back to the studies where they said low carbon dioxide, well, low carbon dioxide is a surrogate variable for overzealous ventilation, and that's what was happening here. So what's your take home? If you don't care about all the physiology here, the take home is ventilation should match perfusion. If you're exercising and you've got high blood flow, you got to have more ventilation, okay? And if you've got a very low flow state, like a shock state or CPR, you don't need much ventilation whatsoever, okay? So that brings us to one of the questions I was asked to address today, which is how about fluids? Well, how about fluids? Okay, why do we give fluids? Should we give fluids? If we have a trauma patient say it looks like they're bleeding, should we give them fluids? Should we? Yeah, why? Because somebody says so, or it's your protocol? Why? Well, people say we got to perfuse the tissues. Well, where'd that come from, okay? So what's the studies that originally got us to that? Back in the 1950s and 60s, there was a set of really elegant studies that were done by people like Dick Wiggers and Carrico and Dillon, others. And what they did is this is a classic example, like in the Wiggers model. They would draw off, like, say, 70% of your blood volume. So if they took the 70% of the blood volume, what happens? Well, within 2 or 3 hours, the animals in this case, these are canine models, they died. What's the mortality rate? It's like 80% of them died when you took off 60 to 70% of their blood volume. Not a surprise. So what would you do to fix this? If you took off 70 to 80% of their blood, what would you do? Give them back, whatever, I mean, not 78, but 60, 70% of their blood. Let's give them back the blood. So what if we restore the blood is the question. What if we restore the blood? Okay. So we do that. Let's wait a half an hour or 45 minutes. So maybe 45 minutes, an hour later, we'll give the blood back. Let's see what happens to mortality rates. Well, the answer is it gets better, but still a lot of the animals still die. Mortality rates were still high. And again, this is not one experiment. This is an assimilation of several of them to give you the general concept of what they were finding in the 1950s and 60s. But what they also began to understand is that when you lose blood, you lose blood volume. You're losing volume from your body. And so what happens is fluid is being lost from your vascular space. So you got lots of fluid in your body, in your cells, extracellular space. So the fluid starts shifting now and going into the bloodstream. And as you're chasing out the blood, you're also chasing out more fluid. So the area that sort of bathes the cells is losing itself there. It's being lost into the bloodstream as well. So they said, what if we give back fluids? Like, at that time, they tried to do something that was like the bloodstream, lactated ringers. What if you add lactated ringers in there? Okay, so let's go for it. And what they found was they did everything. They said, should we give lactated ringers at a 1-to-1 ratio, a 2-to-1 ratio, a 5-to-1 ratio with the blood? And the classic thing that you've learned about 3-to-1 ratio seemed to be the optimal area. And that's what they started doing. And so over the next several years, ATLS for the surgeons and so on, began to have that you restore blood and fluid in a 3-to-1 ratio, etc. And so that's where that kind of came from. And the animals did much better when they got both blood and lactated ringers in a 3-to-1 ratio with mostly fluid, the lactated ringers. So what happened is during Vietnam, we started doing this. It looked like a cool thing. We started taking, as we started EMS systems, we could start giving the fluids right away. So it became kind of a standard of care. And the concept, and we don't know this for a fact, but it looked like we shift the fluid from the extracellular spaces that bathe the cells with oxygen, so we got to replace that fluid, and that's what it's all about. So it became a standard of care, and the idea was, let's give this as soon as possible to prevent shocking from happening, because if we don't, these animals will all die, so to speak, and this time it's humans, not animals, all right? When they gave this fluid back and the blood back, guess what happened? Low blood pressures that were occurring and observed in the situation started getting back to normal. As they normalized blood pressure, urine output went up and everything looked hunky-dory, and everybody went, wow, this is cool. So the concept was, especially if they have a low blood pressure, restore blood pressure to normal. And there was a concept that restoring blood pressure to normal is always a good thing. That would seem like an assumption. So let's give them fluids to get the blood pressure back to normal, et cetera. Then when we get to the hospital, we can look at things like urine output and all that kind of stuff. Okay, so is elevating blood pressure always a good thing? No, why not? You're thinking you might be breaking clots apart? There's more to it than that, too. But well, who cares if you got control of the bleeding, right? Because in all these animal experiments they had done, they pulled the blood off, but they weren't bleeding. But the problem is what? Our animals, so to speak, our patients are bleeding, maybe. They may not have controlled bleeding. We might have control of an extremity injury, and we get control of that, and then that's cool. But if they have, for example, ongoing internal bleeding, like in their chest or their abdomen, is it possible that if we give them fluid, we can make things worse? Well, elevating blood pressure may not always be a good thing for you based on what we were just saying. Elevating blood pressure in uncontrolled hemorrhage could be a problem. So I had a guy who came in once, how I got started this whole thing was we had a guy who got his hand caught in a meat grinder somewhere. And it got all chopped off right here. And he was at a nearby Safeway. By the way, that was my neighborhood. I became a vegetarian for a few months after that. And so he got his arm cut off, and they brought him right in. There was blood all over the store, blood all over the car. But when he got to us, guess what it was? There wasn't hardly any blood there at all. It was pretty much, controlled. And he wasn't even tied off with a tourniquet. So the thing had clotted off, and it had been whatever, but his blood pressure was 70. So his blood pressure was 70, 75. He was tachycardic, cool, clammy. So we said, let's get some fluids into him, right? So we got 2 large bore IVs in, right, in the other arm, by the way, okay? And we started loading him up, and we're talking, looking over this sort of just mangled arm that was brought in from the meat grinder. And we said, there's no way we can fix this, it's gone. And all of a sudden, we heard a blood-curdling cry. Who do you think that was coming from? Patient? It actually was coming from the nurse, because all of a sudden, she was standing right by a thing that was going all of a sudden, just putting out blood. We had raised his blood pressure up, and boom, this thing cut loose again. Guess what happened? We got control of it. It was cool. It was no big deal. But, it had, obviously, as we raised blood pressure, we were making it bleed again, okay? But it actually leaves us with an interesting question. What happens now? We got control of that, but what if it was happening inside where we couldn't see, in the chest or in the abdomen? What if we had raised the blood pressure and blown off a clot, or just overcame the system of clotting off by hydraulically elevating the pressure? And we went back into the laboratory, and we went and asked our surgical friends. They said, is that a problem? They said, well, an extremity, they're very spasmodic arteries and whatever, and so that happens. But, if you did a complete transection, even in the chest or one of these other, it could. You could knock off soft clot. So they're thinking, yeah, because I said, yeah, what about your aortic aneurysms when your GI bleeds? You don't like the raised pressure there. And they said, well, they have clotting abnormalities sometimes. Yeah, but whatever. So we started looking at this concept and went into the laboratory. And what we found actually in the laboratory is that we were actually, if you had uncontrolled hemorrhage, okay, you hadn't gotten control of it yet, we had acceleration of the hemorrhage. We found mechanical clot disruption because we gave it early on when there was soft clot forming before it got to be fibrinous clot. And there was dilution of clotting factors. All those things were found, and we presumed, because we could actually directly observe some of this stuff, that you had a worse chance of getting this to happen when we compared it to leaving you alone. The animals who were left alone did better, interestingly enough. So we decided to do a study of this, and back about 20 years ago, we were conducting a study in which we gave half the people, everybody got IVs, but half the people got fluid, like we always did, until we got to the operating room. In the other case, we didn't give any fluid. We put a saline lock in, and we didn't give them any fluid until they got to the operating room. And interestingly enough, what we found was there were in immediate resuscitation, there were 62% surviving, versus the delayed did much better, and it was significantly better. Whoa, so this got us into a lot of trouble because this made a lot of people nervous, and a lot of people were saying, oh, there's something flawed about the study, and they went through every little thing they could. But the bottom line is our patients did worse when we gave them fluids before they got to the operating room. So like I said, we were attacked after that. We had the independent prosecutor, Kenneth Starr, coming after me, et cetera. But over the next few years, based on those studies, a lot of animal experiments started getting done in uncontrolled hemorrhage in rats, dogs, pigs, sheep, you name it. And every one of those experiments that were done, a detrimental effect was supported in multiple models. And it didn't matter whether you even gave blood or lactated ringers or whatever. If you gave anything that hydraulically raised the pressure, that, whatever, before you got control, made things worse. Now, if you got really bad, like a blood pressure less than 40, then it might be a hypotensive threshold where you had to treat it. But when was the last time you measured a blood pressure less than 75, let's say, in the back of an ambulance? How would you know where and when to take care of this thing, et cetera? And in fact, in our own studies, when we did the clinical trials, it didn't make much difference at all because most of those guys with really low blood pressures like that were dying anyways. They pretty much had already bitten the bullet, so to speak. So here's what I'm left with, maybe. It's like me this morning. First your pants, then your shoes. The fluid's not bad. In fact, I could resuscitate people with fluid alone and do well, but I got to have control of hemorrhage. So maybe it's first control the hemorrhage, then tank them up. So, okay, let's think about that. Well, the truth is rarely pure and never simple, as Oscar Wilde once said. And of course, I'm not intellectual enough for Oscar Wilde, so I have to go along with this guy, okay? And man's got to know his limitations, not only in terms of, let's say, how much fluid I give, but also in terms of our interpretation of studies. We have to understand things and what the perspective and the parameters in which this happened. The studies that I conducted in the 1990s were done in penetrating injuries. These were the reason why I went after them, because it was a simple model. Penetrating injuries who are bleeding, basically you've hit their blood vessel, it cut open a hepatic artery or a splenic vein or a renal artery, etc. And it was a distinct vascular interruption, and that was where the problem was. That's much different than blunt trauma, where you can have diffuse swelling all over the body, multiple contusions, head injuries, a lot of bony fractures, everything. It's a complicated mess. So the problem is trauma is not a generic disease. There's different mechanisms. There's different anatomic locations. Staging is when people say, do you scoop or run or field stabilize? They'd be like answering an oncologist. Cancer, do you do radiation or chemotherapy? Well, it depends. You do surgery. If it's an isolated pulmonary nodule, I might, but if it's spread to the liver, well, that's a different story. So if it's chemo, but if it's leukemia, okay, so it depends on what you're talking about here. So the same thing here. If I've got a guy with an isolated injury in Iraq with his leg falling off, essentially, I can get control of it. That's a different deal than a person with a severe head injury or a person who's got a bad chest injury with potential bleeding inside. But if the guy's been, say, stabbed in the abdomen, he's sitting there drinking a beer and saying, son of a bitch just stabbed me, that may be a different story than the guy who's completely unconscious. I have no palpable pulse, and he's got a huge hole in his chest. So the point is that trauma is not a generic disease. A gunshot wound to the abdomen should not be treated like a severe head injury. So anyways, we said, well, how about blunt trauma? Not stabbings and shootings, but the major car wrecks. What about blunt polytrauma? Car wrecks, falls, explosions. Well, the good news is Drs. Rick Dutton and Tom Scalia and their group in the Maryland Shock Trauma Center went and did their own study. And the interesting thing, the reason why, is that when I was doing our studies and presenting it, Tom Scalia was really skeptical. He said, no, this is not, maybe this is because penetrating, all those things we just said. So great. I mean, he went and said, let's study it. He did both. So he studied both penetrating and blunt, and guess what they found? They found exactly the same thing, although they did look at the subcategory of patients without serious head injury, okay? But if you have blunt injury, penetrating injury, whatever it is, you do better off leaving them alone without giving them a whole lot of fluid, okay, if you haven't had control of the bleeding. So what about head injury, okay? Well, head injury is an interesting question because there have been studies that have correlated a low blood pressure. If you have just one bout of a hypotensive bout, as they say, blood pressure 90 or less, you have a worse outcome. So maybe we need to keep the blood pressure up. Well, is it that, or is the fact that they had a low blood pressure is a marker for them having a bad injury and therefore a worse outcome? So we don't know. But there's some interesting things. Dr. Sue Stern, who's now the chief of emergency medicine at Seattle, while she was at Michigan, did some interesting head injury models. She did all these great studies where she showed you're worse off if you gave fluids early on. But when she took a head injured model, what she did find worse outcomes with immediate fluid resuscitation. Then she went but, and the but comes in, if you had a slow infusion, like maybe not get the fluids on board or waited a half an hour or whatever, it was much better than the traditional approach. And the rationale is that you first form soft clot when you start bleeding, and in the area it may form a clot, and it's a soft jelly-like thing, but it's very fragile and can be knocked off, and it's hard to get that to start up again. But if you let it go long enough, half an hour into it or whatever more, it may form some fibers in there, fibrinous clot. So as that gets tougher, it's a little harder to disrupt that kind of clot. Now, is it too late because the person's bled out? Well, the point is, though, is that if you knock the clot off early on, you may not get them to recover. So the theory here is that maybe we got to be careful even with head injuries. But we still don't know the answer. The problem is blunt trauma is a disease of mass soft tissue injury as far as I'm concerned. And you get into trouble later with things like sepsis and lung failure and ARDS because you have all this inflammatory stuff going around the body because you're just smashed up real bad. Now, I did a lot of studies on this years ago, and I looked at, your chance of getting ARDS if you had 2 long bone fractures, huge long bones would be, 25%, or if you had a contusion, 22%. Well, and if you added them up, if you had a contusion and bone, it went up to 60%, and then up to 90% if you had 3 factors. Well, the reason why, it was, again, a marker for just really being beaten the hell out of, okay? And your body's got inflammatory stuff going all over the place, and it sets off inflammation everywhere, including your lungs, your brain, or whatever it might be. So hypertonic saline was thought to be a way to go about doing this. Hypertonic saline is something that's 6-7 times saltier than lactated ringers, than your bloodstream. So if you put that into the system, you're not getting a huge bolus, but it would have the same effect hemodynamically as about 10 times as much lactated ringers. So you're giving less volume, and it may have an extra protective effect. Not only does it give you a decrease of pro-inflammatory effects, it's been shown well in the lab, but you may have an extra advantage because if you've got a kind of a salty solution in your bloodstream, it basically may prevent edema in your brain from forming. So it was a thought. But here's the but. Always have to look out for the but part. The but part is that the National Institutes of Health recently conducted a study, and under those circumstances, what they found was the hypertonic saline with dextran, which is a large molecule that would make this even more significant, versus hypertonic saline alone versus normal saline, there was no differences in the outcome. Ooh, bummer. So here we thought we had something that might work, and it didn't make any difference. They use this in Europe all the time, so why don't we use it? Well, we found out it didn't make any difference. So that was a problem. So hypertonic and severe head injury, the answer was stop the use, and so people aren't doing that now. All right, so now what do we do now? So that leaves us with an interesting dilemma. Here's a guy, I took this picture years ago, so it's just an old picture, but it just reminds me of the original dilemmas I would be thinking about at the time when we were doing these studies. Here's a guy, look at the old Philadelphia sea collar. It could probably get you a limited range of motion of 10% probably. Any event, here's a guy in a car, he's trapped in, he's got a bump on his forehead, he's sort of breathing, smells like he's got alcohol in his breath, he's got kind of altered mental status, he has a blood pressure of 90, when you feel around, he looks like he's got a definite femur fracture, and then you feel up here, he goes, ugh, when you hit him up in the left upper quadrant. So what's that? Spleen, a broken rib, who knows? So he's got altered mental status, right? That's a problem. So is that because of his low blood pressure, the alcohol, the head injury, the bump on his head? He's got the femur fracture, and he's got a low blood pressure, 80, 90. So we know that you could bleed into your leg, and that's sort of self-limited, so maybe we should give him some fluids. So this guy who's there on the scene plugs in the large bore IVs, gives him some fluids, starting to crank it up. He's got IV fluid here running in. And suddenly a guy there says to him, hey man, maybe we better be careful about this fluid. He goes, why? He's got a big femur fracture. He's going to bleed into that, et cetera, and it's probably causing a lot of his problems. He goes, yeah, but I saw this little short guy the other day, bearded short guy, was telling us that if you have an internal injury, and this guy might have a spleen here, okay, that you can make things worse if you got internal bleeding and you raise the blood pressure. He says, oh, okay, I get it. He goes, okay. And so he said, okay, then turn down the fluids, turn down the fluids. Okay. Then another guy said, yeah, I was at that talk, and they said, you know, if it was a distinct vascular injury, maybe, but if it's like a large organ, like a spleen or a liver, it may not be a problem. He goes, oh, okay, good, we'll turn up the fluids, turn up the fluids. Then he says, yeah, but man, what if this is an avul spleen? He goes, oh, okay, we'll turn down the fluids, turn down the fluids, okay. Then someone says, yeah, but then they said if you had a head injury, you had a bout of hypotension, that it's really bad, so we better, you know, is it too late, or we just turn up the fluids? And they go, okay, I give up. Turn this one up and turn this one down, okay? It's like, you know, it's like, what's the answer? It's not, we don't know, is the answer, okay? We're not sure. But the Army has taken an approach in Iraq, and we'll talk about that in a few minutes in more detail, to basically limit, if you're in deep doo-doo, like you have, they really can't find your pulse, so to speak, and you are not conscious, you may be getting fluid, okay, if you're in a shock state, meaning they're, but otherwise they leave you alone. And at best, even if you're in that state, they might give you 500 mils of very hyperosmotic solution and give it to you maybe over a half an hour and not rush it in, okay? So that's where things have been going. So here's ultramental status, low blood pressure, femur fracture. Where do we go? You know, it's tough. We don't know the answer. So are there any other solutions, so to speak? Kind of a pun here. All right. So how about HBOX? These are hemoglobin-based oxygen carriers. They're actually, you're taking hemoglobin and making them into a new moiety that you could carry oxygen with. And they work really great in the lab. But when polyheme was tested, which is based on human hemoglobin, which you think would be the best thing, it ended up being a negative study. Now, it's a negative study in that it didn't make a whole lot of difference, but they treated a whole broad category of people, even people who weren't that sick, from my point of view, who had, you know, some people who didn't have that much of a chance of dying, and some of them seemed like they had a higher risk of heart attack. So they said, oh, this is harmful to you. On the other hand, if I was basically looking like I was going to basically die, I had a 40-50% chance. If I had a select patient, a group of patients who were really dying on me, I wouldn't care if I was going to have a heart attack if you're going to save my life because I was going to die. So that may have been the study design might be the problem here in some respects. There's another product that's based from cows, bovine stuff, and it's amazing in the laboratory. So if you look at this, for example, there's very compelling data. Brownstein and Manning did a study where they took pigs that they just took off all their blood. They virtually exsanguinated them, got them down to a hematocrit of 1%, and these animals survived. And they were able to transfuse them later, and all that was a bridge to get them alive. So this sounds very promising. And the potential value is there's vast supplies. We eat a lot of steak and hamburgers in this country, so there's a lot of sources of the blood. You can store it in ambulances, and there's less blood pressure elevation that might occur with these things, and still maintains oxygen transport. So that might be cool. The Navy's been trying to push this, but with previous negative studies, the FDA is kind of, you know, doesn't want to do it, but it's probably worth a trial, and we're hoping this is going to happen sometime soon. So I've given you nothing but bad news here. You can't breathe them, you can't fluid them, you can't do anything on them, right? So which way do we go? Well, remember what the Bible said, right? For the life of all flesh is the blood thereof. And the Iraq experience had kind of a silver lining in it, okay? And that is we learned a little bit more about tourniquets, topical products. In other words, these are mechanical ways of stopping the bleeding and some hemostatic ways of doing it, or as you want to say, non-mechanical ways. And we're going to talk about some of the things that they were doing over there that actually may have made outcomes better. And we're going to tell you so the life of Brian Anderson was saved with 3 tourniquets in this situation. So Colonel Craig and others over there did a kind of a cool study where they looked at the CAT. That is the combat blah, blah, blah tourniquet, I can't remember it. And they kept it right there next to their, you can't see it very well, but it's right next to their, carried right next to their ammo on the side there. And all it is a twisty. It's a kind of a thing you put on, it's a twisty is essentially what it is. It's not pneumatic or something like that. And the results of that study was they looked at about, 250 patients with about 400 uses, whatever it was. But they looked at quite a bit over a period of time. And there was no resulting amputation except that due to the primary wound. What are the other things we're worried about? You'll lose limb because of lack of oxygen. Well, there's neuropraxias, meaning, you know, you screw up the nerves. So they had 10 neuropraxias, okay? And 4 were secondary to devices, but all 10 were resolved. And all 10 were life-saving. So that was pretty impressive stuff. How about Clot Muster? So part of it is you can put topical stuff on it. And they used Quick Clot over there for a while, and that's HemeCon. It's kind of like, some stuff you might get at the beach, okay? And what happened here is that it's chitosan, and it's kind of like shells and things like that that are used, but it causes kind of an exothermic reaction, which means it was hot and kind of burning, and it was about $100 a pop. So they didn't use it liberally. They used the gauze wrap first, but if there was too much blood and it kept slipping off, then they'd go to this dressing. And there are new forms now. The next generation has less exothermia, it costs less, and it's looking better. So we don't use them in EMS all the time, but we do save them most of the time in our area for the tactical areas. The thing that really became very impressive over there was the liberal use of fresh frozen plasma. This is basically stuff that has all the clotting materials in it, in a sense, okay? And what they found is that when they gave the fresh frozen plasma, there were striking improvements in outcome based on the ratio of blood to fresh frozen plasma. In the past, we used to give blood, we give a little more blood, and we got up to about 8, 9, 10 transfusions. We said, we better give some fresh frozen plasma. Now, this is hours out, and we're giving it after the fact, okay? And these patients often would continue to bleed. If you had 1 to 8 ratio, like 1 frozen plasma for 8 transfusions, they had a 67% mortality. When they went back and reviewed cases and they found the ones that got like a 1 to 3 ratio, as they started becoming more and more liberal about this, it halved the mortality. And you take it further, when they looked at like a 1 to 1 ratio, it went down to like a 19% mortality. And there's some laboratory stuff that's going on to say maybe even more is better. Maybe you don't need as much. You stop the bleeding and you'll make it better. So the ratio of blood products transfused basically looked better if you gave more of a 1-to-1 thing. And then platelets too, they started adding platelets in there. Now they're looking at a 1-to-1-to-1 ratio. Blood, platelets, and fresh frozen plasma. And what you get is what they call damage control resuscitation. It's a non-mechanical hemostasis, control bleeding that way. And so what happened under these circumstances, it seemed to be synergistic. They did even better. And the transfusion risk, that is the transfusion-related allergic reaction or bad reactions, was very low, 1 in 10,000. And this completely decreased, in their experience, the observation of multi-organ failure. So things were getting kind of better with all this, and it decreased blood utilization. The civilian experience in this country recently has corroborated this to some extent, and they look like if you use this, they tend to have improved outcomes. And if the high ratio of plasma and platelets not only improved outcomes, but also it looked like it helped to have an impact on blood utilization. You didn't have to use as much blood. So as a result, this looked like it was saving money, even though you're giving more fresh frozen plasma. You may be saving money in the long run because people weren't using as much blood products as they used to. So maybe there's something to all this. Well, some folks say there's a survival bias in these studies, because you're looking back at what happened. What does that mean? A survival bias means what Snyderdahl said, maybe what it is to do that, the question is, do surviving patients get more plasma and platelets because they are bleeding, okay, slower, therefore they're less sick, and thus they live longer to get more product. So in other words, the patients who weren't as bad off, who were going to survive anyways, got a lot more product. Or do patients receiving earlier and larger amounts of plasma and platelets actually bleed less thanks to the therapy, thus surviving? And that question is basically not quite clear yet, okay? But if it does work, how do we think it works? About 2 minutes, is that okay? How do we think it works? Transfusions. 25% of the people who get transfusions basically do so in the first 4 hours. Only 3% get mass transfusions though. And who gets mass transfusions? It turns out that they're the ones who basically will die from potentially reversible cause. So this is critical to us all. It turns out who gets mass transfusions, and actually it's interesting. There's a group of people, 30% of all trauma patients, that means all of us, okay, because any of us could be a trauma patient, have a coagulopathy. By having trauma, it sets off a kind of a coagulopathy as trauma, as they call it, okay? ATC, acute traumatic coagulopathy. If you get an increased coagulopathy, if you got that coagulopathy, you die. I mean, it's a much better chance that you'll die. And it's unrelated to the injuries. In other words, no matter what the severity, location, whether it's penetrating or blunt, this seems to be an independent factor. And some people relate it to having a coagulopathy because of certain things like lack of protein C. Is it genomic? It may be a genetic phenotype, meaning that you have a problem with your protein C pathway. It means that you protein C is important in coagulation, and maybe you have a problem with that, et cetera. So it's worsened by a traumatic inflammatory response. You have lower protein C levels, and you don't clot as well. So that may be what's going on. So as it turns out that it looks like when they look at those patients who have that coagulopathy, the new approach seems to be working better. So then there are new survival guidelines and curves that are coming up in our civilian populations in the United States. It's now identified that most people now die in the first 6 hours. That's probably from exsanguination. That the FFP, the fresh frozen plasma effect, is observed in that time frame. But if you go out beyond 6 hours, like we used to do in the old days, it doesn't seem to make much difference. So it's really critical to see what you do in those first few hours. So some evolving thoughts are that many trauma patients have a deadly coagulopathy. You give them early fluids, okay, and late use of plasma platelets, that contributes to bleeding and death. But an early intervention is the key. And well, how do you predict who's going to need that early intervention? Well, the good news is coming down the line for you in EMS is probably looking at lactate. For example, there are now point of care, that means things you could take out there like a pulse ox or whatever, you can get a blood level or glucose level, right? Point of care testing. You can look at lactate now. There's new machines, and in one study in which they had 265 patients with a normal blood pressure and pulse, if they had a point of care lactate level greater than 4, this completely predicted a need for emergent surgery. So we may be able to predict who's going to need to get those transfusions of the fresh frozen plasma right away and maybe help them out under those circumstances. So there may be things coming down the line that's going to be, I like this, when we're going to do some new studies. In fact, this is one of the studies that the NIH is doing right now. I like this, experimenting with acid, and because new meaning to it. It's one hell of a trip. I'm going to skip the intraosseous because of time, but I think most of you are using it out there. But one of the things we're thinking is that we can now get the lines in earlier, get things going earlier, and so on. And it's just kind of a neat thing. Now, I'm going to it's time to wrap up from you. Should I be wrapping up now? Huh? Yes? Yes, wrap up? Okay, good. Then what I'll do is I'm going to come back maybe some other time and talk about one other attractor. Is that okay? You got time? Are you really okay with this? Because this is going to be fun, right? So should I do it? Yes. Be about 10 minutes. Okay. Okay, there's one other very attractive possibility that's coming up here, okay? Very attractive. It's my daughter, of course. So, in any event, and that brings us, of course, to sex hormones, all right? What? Looks like I got shut down here. Okay, here we go. Let me just show you one thing, because you're going to go, sex hormones, what's that all about? This is a trauma talk, right? So, here, let me show you. Got a movie for you.
Patient has a fractured fibula.
Patient has a fractured fibula, mild sedative. He'll probably go home tomorrow.
So I could be able to go home tomorrow.
Daddy's going to be so excited.
That killed him.
So under the category of don't judge too quickly, okay, let me give you some interesting things we're going to go over here in a second. And this is the use of sex hormones in resuscitation, okay? And I hope you find this interesting. There's been some work done a few years ago where they actually looked at progesterone causes decreases in edema, particularly brain edema. And so a study was done, again, in very serious head injury cases, over in Georgia, in Emory in Atlanta. And they looked at head injury patients coming in, and progesterone seems to decrease brain edema. So they decided to give it. And they just did a feasibility study to see if it's safe. And what they found out, you see here on the right, that's a placebo. The mortality rate for the group of patients that were entered in the study was 30%. But in the group that got progesterone, and even some of these got the progesterone late, it was impressive. It was only 13%. So this is just a preliminary study, but those are pretty compelling data to look at that. And so there's a big study going on now called the Protec Study, which is looking at, it's an international multi-center study that is looking at the use of progesterone. Now the problem with progesterone is that it has to be given often later on. Usually it's given in the hospital. It's on a drip and you get it for several days. There's another drug that's pretty impressive because all you have to do is give a one-time dose, and I'm predicting in a few years you'll be giving it right in the back of your ambulance. Men with good outcomes have been found at our center to have high cerebral spinal fluid levels of estrogen. In their brains, normally you have low estrogen if you're a young male, and your estrogen level, though, in your brain is even lower. It's 1/10 of what's in your bloodstream. Any women in the audience will tell you that, okay? So as a result, what happens is, it's interesting with a bad head injury, the men who have good outcomes, when we were doing our studies, we found, we didn't know this, we weren't looking for this, we just found that the men have higher levels. We're going, what is that about? That's interesting. And we said, is it sequestered? We actually studied it further in the laboratory. What we found is that it's produced. It's like the brain knows if you're in trouble, you better produce some estrogen. So what's that all about? Well, numerous cell culture animal studies in models ranging from primates to mice have all pointed to the finding that sex steroids influence the degree of injury and the recovery, both in trauma patients and people with transient ischemia and reperfusion injuries, etc. And the spotlight today is going to be on estrogen because this, I think, may be something you may be able to give, and I may come back and talk to you about it in more detail next year. The protective effects of estrogens are neither cell type nor insult specific. So it doesn't matter if you have a stroke, it doesn't matter if it's a head injury, if it's a cardiac arrest, and it doesn't just go to breast tissue or ovaries or something. This, I'm telling you, it goes into every cell in the body. It's lipid soluble, it goes to the cell walls, it goes down to the mitochondria. And that's where we think it works. For example, in the stroke, the classic thing where you have the penumbra, where the cells around it are dying. The stroke has occurred in an area, and that it says signals that kill all the other cells around it. The misery loves company thing, I call it, okay? Well, what happens here, it sends this thing, stops that from happening. It upregulates the mitochondria, it keeps them alive, and it keeps it going. It's really fascinating stuff. So, one of the worst things that happens to you, for example, in a burn, is even if you have a big torso burn, other sites distant, remote from the burn site, like your brain or your lungs, are the reasons why people get into trouble. Lungs is the #1 cause of death, and interleukin-6, an inflammatory marker, okay, IL-6, basically goes sky high and it correlates with the lung failure. We have done in our own laboratory, given estrogen and completely prevented it, and the lung function remains normal too. And this is even though we see tons of IL-6, the inflammatory markers, in the burn charred parts of the skin, etc. We're able to prevent it. So it's kind of fascinating we're doing this. I mean, it happens in spinal cord injury, etc., and let alone on and on. Look at this. This is like a stroke model. You take a rat, okay? And we're not talking about you got the estrogen in your system. We're talking about we let you have a stroke. We wait not 10 minutes when brain damage could occur, etc. We don't wait 15. We talk about 40 minutes later, you tie off the cerebral vascular artery, and 40 minutes later, you go ahead and give some estrogen there. And then what you're looking at here is on the right is the estrogen in animals and the left placebo. And you can see in the placebos, there is kind of that white area. That's infarct. That's dead tissue. And you compare it to the ones that didn't get it. So this is like, to some extent, I'm seeing this go, this is too good to be true. This is really weird, eerie, okay? So we're doing studies on this now. We're doing clinical trials in Dallas to see if this will work. We don't know the answer because we're blinded. We don't know who we gave the estrogen to, who we gave placebo to. A certain board looks at this, a data safety monitoring board reviews it, and they said there's been no complications. We're not surprised because IV estrogen is given all the time to a lot of people for various reasons. People with dysfunctional uterine bleeding, people with prostate cancer, and a bunch of other cases. We've had decades of experience with safety here. So here's something safe, and it's actually inexpensive. And I will come back and give you more details about this. But in summary, on the road to the 22nd century, what I hope to be able to tell you that with the things that we're learning now, the new approaches from the war, at the same time, coupled with things like what we're learning back home with sex, okay, that the dead shall be raised. We hope that more of the dead shall be raised, and that will make life better for future generations. Ooh, wrong slide, future generations. So with that, I want to thank you very much for your patience with me today, and if you have any questions, I'll be glad to take them. Okay. Want me to take questions? Yeah. Okay. I guess I'll go ahead and take some questions if anybody has anything for me. Do you see this? You have a question? Okay, here, why don't you sit you right here. Go ahead. Speak into it.
Doesn't giving estrogen increase risk of like PE and, I mean, are you just...
Yeah, so great question, because she was saying that if you take estrogen, don't you get a high incidence of blood clots and PE? And that's a good question because in a previous study, that's what was found, particularly people on contraceptive devices have had that. But the interesting thing about that is that, in fact, they recently did a study. They showed it was for a combination of estrogen and progesterone that caused that problem with long-term chronic oral use. When you give it IV, first of all, it's estrogen alone is not the problem. And when you give the estrogen, you bypass the liver and you bypass the secondary, what they call first pass effect in the liver, which was thought to be responsible for those prothrombotic effects. So that's why we think the IV, one dose, not a chronic dose, is different, okay? Any other questions? So anybody think this is interesting? If you want, I'll come back and talk to you more about it later on, so okay, good.
We'd like to thank Dr. Pepe and all of our speakers for what I think was a great forum today. I'd like to thank all of you for coming. Just a couple things. Your certificates are immediately outside in the lobby, and please turn in your evaluations. And next year's conference will again be during EMS week, and just remember what you guys do is incredibly important. We thank you from the bottom of our hearts. Thank you.